So to avoid confusion, I have put up this table. So this table summarizes the clinical frequencies, prognosis, immunophenotype patterns of the BALs that are grouped under the other defined genetic alterations in the WHO 5th edition. So we are looking at the 7 subtypes, which is DUX4 rearranged, the MEF2D rearranged, the ZNF384 rearranged, PAX5 altered, the PAX5P80R, the NUTM1 rearranged, and the MIC rearranged. For each of these, we compare how frequently they occur at different age groups, what is the prognosis like in children and in adults, what are the characteristic immunophenotype that can help us with suspect of the subtype and flow cytometry level, and let's go by this row by row. First is the DUX4 rearranged row. So first, DUX4 rearranged BALL in terms of frequency, it accounts for about 4 to 5% of the BALL in children less than 15 years. And it increases to 8% in 16 to 39 years age group and is around 3% in the adults beyond 40 years. Prognostically, this is one of the best subtypes in this group. The children have good prognosis with high long-term survival despite having very high early MRD levels. Adults also generally fall into good prognosis group compared to other adult BALL. Immunophenotypically, it is characterized by the CD371 positivity, which is a key marker to remember. The CD2 positivity is there in 70% of the cases. Increased expression of CD13, 34 and CD38 also can be seen. So whenever you see a BALL case with CD371, CD2 positivity and a DUX4-like expression of profile, think about the DUX4 rearranged BALL, which carries a relatively favorable prognosis. The next row, we see the MEF2D rearrangement row. The MEF2D rearrangement row is the second row. So when we are looking at this, we see that it is less common than the previous counterpart we saw, with 1 to 4% of the cases in children, 3% in 16 to 39 age group, and 1% in the older adult. The prognosis is intermediate to poor in both children and in the adults, and the outcomes are worst in the adults. The immunophenotype is quite characteristic with CD10 negativity, CD5 positivity, CD38 positivity, and frequently cytoplasmic mu heavy chain positivity. So this profile BALL, CD10 is negative, CD5 is positive, and mu positive should trigger a suspicion of MEF2D rearranged disease, which tends to be more aggressive and needs a careful risk-adapted therapy. The next row is the ZNF384 rearrangement. The ZNF384 rearrangement row is the third row. Here we see that the ZNF384 rearranged BALL contributes to about 1 to 4% of the childhood BALL, 4% in the 16 to 39 group and 3% in the adults. The prognosis is about intermediate, but importantly, it can depend on the fusion partner that is available and overall mutation background in toto. So the immunophenotype features include CD10 negativity in about 73% cases, myeloid antigen expression of CD13, 33, CD65 is negative, CD15 is negative, CD25 is positive in quarter of the cases, and MPO is negative in BALL, but can be MPO positive when some fusion is there, which represents an MPAL type of a profile. So this subtype often shows some lineage plasticity, and you may also see some myeloid features or even transformation into a myeloid phenotype in the relapse. So the BALL with CD10 negativity and myeloid marker positivity should always make you think of the ZNF384 rearranged disease or MPAL with ZNF384 rearranged. The fifth row is the PAX5, the PAX5 alteration. So it has a relatively broad category between 3 to 9% in children, 9% in 16 to 39 age group, and 3% in the older adults. Prognostically, the PAX5 altered BALL shows intermediate risk in children, poor outcome in adults. In terms of immunophenotype, there is no single consistent pattern strongly associated across all these cases. So the WHO mentions that there is no specific immunophenotypic association reported in the PAX5 altered group. The key point here is that whenever the PAX5 is altered, it is a genomically defined cluster and not an immunophenotypically defined one. So you need an NGS-based mutation fusion or amplification data to identify this subtype. The next row is the PAX5P80R row. So now this subtype is less common. So it is about 1 to 2% in children, about 3% in 16 to 39 age group, and about 4% in the older adults. The prognosis again intermediate in children and surprisingly good in adults compared to those of children, and many older than many other adult BALL subtypes. Immunophenotypically, the cases tend to show CD2 positivity, CD33 positivity, and CD65 negativity. CD15 is also negative. So when you see a PAX5PATR mutation plus this pattern of markers, you are dealing with a specific genetic subtype that has different biology and prognosis compared to the PAX5 alt. The next row is the num1 rearrangement. The num1 rearrangement BALL accounts for 1 to 2% of the pediatric BALL overall, and in infants it is 3 to 5%, particularly associated with certain germline KMT2A rearrangements. It essentially is not seen in adults so far. So the prognosis is called to be intermediate in infants and is more favorable than classic KMT2A rearranged infant ALL. Immunophenotypically, no single characteristic immunophenotype has been consistently reported, and WHO lists no specific such association in the Blue Book. The important point is that the NUTM1 is more therapeutic and biologic because it affects the chromatin acetylation. So it may respond very well to the HIDAC inhibitors and potentially a bromodomain inhibitor in selected fusion. Next, last we would see the MIC rearrangement. This is the last row. So the MIC rearrangement row, let's look at it. So this is seen in children less than 1%, but about 1 to 2% in 16 to 39 age group and 2 to 3% in adults. The prognosis generally is poor both in children and adults, but practical management differs. In children, the MIC rearranged BALL is often treated with Burkitt lymphoma-like regimens, and this improves the outcome significantly, while in adults, the 5-year survival is often below 20%, making it a high-risk entity. Regarding the immunophenotype, there is no distinct reliable pattern that is consistently associated. So again, the WHO states no specific association as reported. One critical point is that the adults mixed rearranged BALL must be carefully distinguished from the double hit or triple hit lymphomas, as the latter has a specific diagnostic and therapeutic implication. So this table essentially gives you an at-glance map of all the other defined genetic alterations of the BALL. It tells you how each common subtype perform at different ages. So it signals at the good actors like the DUX4 rearranged and the NUT M1 rearranged versus the bad actors like the adult MIC-R and the MEF2D rearranged. And it provides a key immunophenotypic clue that you can look at during flow cytometry and specific genetic tests. In practice, you will often use these immunophenotypic hints to triage the cases for appropriate NGS and FISH panels and integrate the morphology, flow, and molecular data. So save this video for your further diagnostic practice.